Well, thank you, Mr. Secretary, for being here. I would say that there was actually an agreement between both sides on the Alexander Murray legislation and a strong list of bipartisan sponsors. And it's unfortunate that because there was opposition from the White House, because there was opposition from the leadership in the Senate, that bill wasn't able to come to the floor. And I would encourage you, I think everybody who has been in the Senate since we passed the Affordable Care Act recognizes that we need to improve some things, that some things are not working. But the response is not to refuse to come to the table. It's not to overturn the law so that people have no alternatives. The answer is to work together to get it done. And I'm very disappointed that we have not seen that kind of leadership either from the Senate leadership or from the White House. So I hope you will share your views that you think there are things we could do together, because so far that's been missing from the conversation. I want to just agree with Senator Manchin of the importance of the set-aside on the opioid funding. It has been critical in a state like New Hampshire where, as you know, because you're familiar with it, we have a huge problem. We are behind West Virginia in terms of the overdose death rate, but way too high for our state. We have way too many families who are affected, and the pain is, you can't talk to anybody in New Hampshire who doesn't know someone or hasn't been affected personally by this epidemic. And those set-aside dollars that have been used for the state opioid response grants have made a huge difference in New Hampshire. It's allowed us to set up a hub-and-spoke system that keeps people within an hour from a place where they can get treatment, which has been very important. We're still waiting to see exactly how this is going to work, but it's an improvement and something that would not have been done without those dollars. We had a hearing here a couple of weeks ago, and I was talking to you about it at the start of this hearing, where there were people from states across this country who were directors of programs to respond to the opioid epidemic. And I asked them all a question. One was from New Hampshire. She heads a recovery center. I said, what happens if these federal dollars go away? And she said, well, I'll go back to bake sales. Some of the other folks were a lot more direct. They said, people will die. And in New Hampshire, the expansion of Medicaid has been one of the things that has been most critical to ensuring that people can get treatment and that we can prevent some of those deaths. And yet, I share the concerns that Senator Murphy was raising about what this budget does to repeal the Medicaid expansion and replace it with block grants, because not only does it cut the amount available to states, but it assumes then every state is going to come up with the funding to replace that, and I think that's a huge question in a lot of the country. So can you talk about what we should say to those people who are running the programs to address the opioid epidemic about what they should do if these federal dollars go away?
Well, I appreciate your concern. The President is adamant, our budget reflects this, about the funding and support for the opioid epidemic and the work that we have together, and want to keep working with you to ensure the states that have the highest burden are getting the share of resources that they need to deal with this. In addition, our budget proposes with Medicaid that we would actually expand access for women postpartum for 1 year. To have eligibility postpartum who are suffering from addictions. That's one of the changes we've got in the budget. We continue to process the IMD exclusion waivers to ensure that we have inpatient capacity and expanded capacity for inpatient in communities. So we're continuing to drive forward fully engaged, fully focused around the opioid epidemic. We're seeing the results where we targeted the state opioid response grants actually to ensure access to medication-assisted treatment, you know, the gold standard, and I think we're helping to really just expand capacity by making it quite clear that this is the most evidence-based approach to people for treatment and lifelong recovery.
Well, I appreciate those changes. I think they're very important. But if the fundamental funding source and coverage source for people to get treatment goes away, then those will make a small difference, but they won't address the underlying problem. Can I ask one more question, Mr. Chairman? Yesterday, a study from the Kaiser Family Foundation found that Medicare Part D spending on insulin grew by 840% between 2007 and 2017. As you know, diabetes is one of the most expensive chronic illnesses we have in this country, and figuring out how to help patients with the cost of insulin at the pharmacy counter is very critical, but it's also a question about how can we be most effective with our public dollars to address illness. So I know that your department has proposed new rules to limit the impact of pharmacy benefit manager rebates that have helped to drive up the cost of Part D drugs. Can you tell us whether you think removing that link is going to help address things like those insulin costs, or do we need to be doing something else?
Well, I would defer on the something else side, but I can tell you that the rule that we have proposed to get these rebates out of the system and instead have those go as discounts to the patient at the pharmacy level would be revolutionary for the patients in the situation you're talking about, especially classes like insulins or arthritis medicines or high-cost cholesterol medicines that are very highly rebated now. You might have in some of those classes average 70% rebates. Imagine January 1 of 2020, when that patient walks in the pharmacy, if this rule goes forward, they will get a 70% discount every time they fill that prescription. It's a revolutionary change for patient access and affordability if we can get this through. And I pray that we'll have your support to help do that. It's $29 billion of rebates that are going to PBM, the pharmacy benefit managers now, that would go to patients starting January 1, 2020, if we can make this happen.
Well, I look forward to hearing more about it. Thank you.
Senator Murray.